All right, welcome everybody to the September 2024 Educating and Empowering You program. We are sponsored by Boone County Hospital Foundation, and I am your host, Sarah Clute-Bain, the Foundation Director. For the program today, if you're joining us live, please put any questions you have in the chat, and we will make sure to address them by the end of the program. In today's program, it is called Revolutionizing Spine Surgery with Dr. Zaki Ibrahim, a renowned spine surgeon with Capital Orthopedics, and he will begin serving our patients here at Boone County Hospital in the clinic in October. He specializes in the latest advancements in spine surgery, including minimally invasive techniques and motion preservation strategies. His expertise is helping patients experience quicker recovery times and better outcomes by reducing the impact of traditional surgical methods. So today, he will discuss how those cutting-edge innovations are informing and transforming the field of spinal care and improving patient quality of life. So welcome, Dr. Ibrahim, and I'll let you get started.
Thank you very much, Sarah. As Sarah mentioned, my name is Zaki Ibrahim. I am an orthopedic fellowship-trained spine surgeon. I've been in practice for over 20 years, most recently in Denver, Colorado for 20 years exactly. And I decided to move my practice to Iowa and spend my last decade here taking care of patients in Iowa. And I'm really excited to be a part of the community here and to be affiliated with Boone County Hospital. And so, as Sarah mentioned, I'm going to pull up my talk here, and the title of the talk is somewhat of a passion of mine, and it's entitled "New Spinal Technologies: Progress, Indications, and Pitfalls." And this is something that is very much a passion of mine. I am very inclined to search out new technologies and find better and less invasive ways to take care of patients. And that's kind of been something that I've really strived towards over the course of the past 20 years. So I'm going to start out by just kind of talking about the different areas of the spine. So the spine itself is split up into three main areas, and then the sacrum. So you have the cervical area, which is the area that comprises the bones in the neck, the thoracic area, which is the part of the spine that extends through the thoracic cavity or the chest, and then the lumbar spine, which is also a part of the spine that can give you problems, and that's in the low back. And then at the very bottom, you have the sacrum, which is the part of the spine that attaches to the pelvis. And importantly, the two portions of the spine that move are the cervical and the thoracic spine. The cervical and the lumbar spine. The thoracic spine is stabilized by the rib cage. So as a result, you have very little motion in the thoracic spine. So because of the motion that's generated in the cervical and the lumbar spine, those are the portions of the spine that wear out. And those are the portions of the spine where over 95% of interventions are carried out. Okay. So every part of the spine is comprised of these structures here. You have the vertebra, which are the bony building blocks of the spine. You have the discs, which are the fluid-filled structures in between the vertebra. You have surrounding ligaments, which stabilize the spine. And then you have the nerves, which are in the back of the spine and extend out into the soft tissue surrounding the spine and go down the arms and the legs. And that's how you control and you feel with your arms and your legs. So the degenerative process begins in the discs. The discs are the shock absorbers of the spine, okay? And the disc is made up of the annulus, which is it's like a jelly roll. So the annulus is the outer portion of the spine, which contains the jelly, which is within it. And the jelly is the part of the spine that does the shock absorption. It's important because this is where the degenerative process begins. And what happens over time is that the disc actually becomes less hydrated, it loses fluid, it becomes flattened, it becomes stiffer, and that is the part of the spine which precipitates the whole degenerative cascade. This continues in the surrounding bones. You can see here as the discs start to collapse and they start to lose height, you can have disc herniations or disc bulges. The disc itself can become unstable, or frequently you'll have these osteophytes or bone spurs, which occur adjacent to discs that are degenerative. And all of these structures can give you pain and discomfort in different ways um, uh, following the degeneration of the process. So we're going to start by talking a little about the cervical spine, and this is the area in your neck. And so this is a fairly accurate depiction of the cervical spine, looking at it from the side. Okay, the right side is the front of the spine, the left side is the back of the spine. You can clearly see the vertebra, which are the bony building blocks. You can see the discs in between, and you can see the nerves in the back. And what happens importantly is as these discs start to degenerate, they lose fluid, they become collapsed. The space for the nerves also becomes compromised. And the space from the nerves can be compromised either by the disc itself, much like if you consider a disc, I use this analogy frequently because the disc is shaped like a marshmallow. As the disc collapses, it tends to bulge around the periphery, and that can cause nerve impingement, or also the adjacent bone spurs, which are on either side of the disc. Um, Part of a more chronic process can enlarge and start to compromise the nerves in the back. I tell patients that all this stuff can happen either in the front of the spine or in the back of the spine. In the front, there's plenty of room, and it usually doesn't cause a problem. But in the back of the spine, the area for the spinal nerves and the spinal cord itself is very limited, and it can very frequently cause a problem. Cervical radiculopathy is a manifestation of disc or bony pain in the cervical spine where an individual has pain in the neck that extends down the arm. And this is it's kind of like lumbar sciatica. It's a very electric form of pain. Um, it's um, it's like a toothache that extends down the arm, and it can extend down the arm in a variety of distributions. Usually C6 pain or the C6 nerve root will give you pain that goes into the thumb. The C7 will give you pain that goes into the middle finger, and then C8 and T1 on the ulnar aspect of the arm and the hand, respectively. Cervical myelopathy is different than cervical radiculopathy because this is a compression of the spinal cord itself. And so it's a far less common but more serious problem. And typically, instead of having pain or weakness in a very specific distribution, these individuals can have much more diffuse symptoms of a spinal cord dysfunction. For example, they can have upper extremity clumsiness or difficulty holding on to items. They can have difficulty with fine motor functions, such as using a key or using a pen. They can have difficulty with gait or balance, and they can be hyperreflexic. And usually the natural history of cervical myelopathy is that of a gradual, stepwise loss of function over time. So this is still one of my favorite operations. The anterior cervical discectomy and fusion is what I call the workhorse of cervical spine surgery. And despite this is really, and what I mean by workhorse is that it comprises nearly 80% of all spinal procedures done on the cervical spine. And with appropriate indications, it's reasonable to expect greater than 90% good or excellent results. And it truly is a minimally invasive technique. And usually people that have this kind of a procedure out of the hospital or out of the surgery center the same day. Nevertheless, problems remain. Okay, whenever you're trying to fuse part of the spine, you're trying to eliminate motion, there's always the possibility that something doesn't fuse. We call that a failed fusion or a pseudarthrosis, and there are risk factors associated with having a pseudarthrosis. We know that the likelihood of having a pseudarthrosis increases with the number of levels included in the fusion. Usually these are not symptomatic at the beginning, but they can become symptomatic with time, and indeed over 50% of the time they do. The other thing that I want to mention is that with any kind of a cervical fusion, as I tell patients, it's a very good but imperfect operation because anytime you do a cervical fusion, you're mitigating pain by eliminating motion. Well, the cervical spine was designed to move, and so that motion tends to want to go somewhere, and it can go to an adjacent level. And so what can happen is that adjacent level can wear out at an accelerated rate, and that's been looked at. And in the literature, we know that the rate of adjacent segment degeneration is approximately 2 to 3% per year. So, with regards to anterior cervical discectomy options, again, the anterior cervical discectomy infusion is still the workhorse of cervical surgery, but there are some issues with this kind of a procedure. Nevertheless, about 80% of all cervical procedures involve some form of anterior cervical discectomy infusion. And it's a very appropriate surgical procedure because most compression in the cervical spine originates in the anterior portion of the cervical spine. Nevertheless, there is a promise of motion preserving cervical surgery, artificial disc surgery. This is very promising, but as we'll talk about in just a couple of minutes, there are some limitations. And then the posterior cervical fusion is an operation that historically I have just hated. While it's necessary sometime, I feel that it's a very destructive kind of an operation because it does involve a lot of muscle stripping and taking down of tissue that never really kind of heals the way you want it to. And so I've been very actively involved in finding better ways to do this kind of an operation, and we're going to be talking about that in a few minutes as well. So again, the anterior cervical discectomy infusion, this is a depiction of it. Typically what we do is we take the disc out, we put a piece of bone or a cage in the space that was previously occupied by the disc, and we put a plate in the front of it so that over time a fusion occurs. And again, this is indicated for almost any kind of operation in the cervical spine, for multi-level disease, for single-level disease, usually is indicated for older patients. And absolutely when there's minimal motion demonstrated on x-rays. So this is the sexy thing. The anterior cervical discectomy and disc replacement is an operation which is very similar to the anterior cervical discectomy infusion, but indeed it preserves motion at the affected segment. And because it preserves motion at the affected segment, it indirectly decompresses and preserves the adjacent segment. So there is mounting evidence that by doing an anterior cervical disc replacement, you preserve the adjacent segments as opposed to predisposing them to an accelerated rate of degeneration. Again, there are limitations, okay? Because stability is a concern, these kinds of procedures are indicated for only 1 or 2 levels. So if an individual has problems at 3 levels, then they're kind of out of luck, okay? Usually, the rule of thumb is that there has to be retained motion at the segment that is indicated for surgery. Okay, the rule of thumb is that if there is motion there, as demonstrated on flexion and extension x-rays, then that patient is a candidate for artificial or anterior cervical discectomy and artificial disc replacement because that disc replacement will preserve motion that's there. If there's not motion there, then an artificial disc replacement is the wrong operation to do because an artificial disc replacement will not restore motion. It will only preserve motion if it's there. And that actually limits a lot of people from having this kind of technology. So here's an indication of an individual that had, this is a perfect kind of a procedure for this particular individual. This is a 45-year-old, relatively young female who had severe pain going down her right arm as well as right-sided neck pain. This MRI here in the upper right corner. The right is the anterior portion or the front of the spine. The left is the back of the spine. You can see the square-shaped things in the front of the neck. Those are the vertebra. The discs are in between each of the vertebrae, and what you like to see is the back of the vertebra and the back of the discs being fairly even, but what we have here is a single level disc herniation, which is causing the patient severe pain. So this individual did have retained motion, as we will see in a following slide. So as you can see here, if you look at the C4-5 disc space, if you look at these things in the back, we call these spinous processes, you can see how they open up in flexion and they compress down in extension. So this patient clearly has retained motion at the C4-5 segment. This is one of the disc prostheses that I frequently use. It is, as you can see, it's a poly-metal sandwich. Not only does the metal flex and extend in motion, but if you pay close attention to the poly, you'll see how it translates posteriorly or in the back when the patient is flexing the spine, and it translates anteriorly when the patient is extending the spine. So you can see it move backwards there, and you can see it move forwards as the patient extends the spine. And that's important in recreating some of the normal physiology that you typically see in a biologic human intervertebral disc. So this individual underwent this operation. You can see here at the C4-5 level where you can't see the poly portion of of the disc prosthesis, but you can see the metal portion, and you can see in extension how it opens up, and in flexion how it flexes, and how it opens up in the back. And so this patient had a very good result with complete resolution of neck and arm pain, and she was back to playing volleyball within 4 weeks of the operation. She went home the same day. So here's an individual that has the same degenerative process going on a little bit further along the scale. Obviously, this individual is significantly older. He's 68 years old. Instead of having the radicular symptoms or the symptoms going down one arm or the other, he had bilateral upper extremity clumsiness. He had difficulty with gait. This individual truly had what we call cervical myelopathy or cervical spinal cord symptoms. So here is a cross section of an area of the spine where you see the spinal cord intact, and you see the white stuff surrounding the spinal cord. That's all CSF. You can see the spinal cord itself being round in character. And this is one of the levels that's very, very affected. And you can see how the spinal cord is actually compressed and actually kind of refashioned or reshaped into a U shape as it's kind of draped over this anterior bone spur. And so this individual was not, because he had very little motion, he had multiple level disease, he was not a candidate for any kind of anterior cervical discectomy and disc replacement. He underwent a 4-level fusion and initially had an excellent result and did very well for about a year. And about a year after surgery, he said, "Hey, doc, I'm starting to have some neck pain. It's really bothering me." And so we got these x-rays. And what you can see is that he's fused at 3 levels. But we were talking about pseudoarthrosis before. You can see I put this line, you can see how things open up in flexion and they close down in extension. So this individual had a failed fusion or a pseudoarthrosis, which was giving him a problem, which is a known complication of any kind of anterior cervical discectomy and fusion. So pseudoarthrosis has been documented in cervical fusion since we began doing them in 1955. This is a landmark study. It's an old study now. It's over 30 years old, but it was the first study that really kind of indicated that pseudoarthrosis, the rates of expected pseudoarthrosis are related to the number of levels included in the fusion. Okay, so the more levels included in the fusion, the higher the likelihood that you're going to end up with a failed fusion at one of those levels. You can see here, this is a 2-level fusion, and you see the cleft here at the bottom. And even in 1-level fusions, it happens less than 5% of the time, but occasionally you'll see it. An individual that will have a very successful initial outcome, but over time will develop some neck pain. These are some of the common risk factors associated with a pseudoarthrosis occurring. Smoking is a big one. People that have smoking histories are 3 to 4 times more likely to end up with a failed fusion at 1 or more levels. Comorbidities such as diabetes, autoimmune diseases, connective tissue diseases also are correlated with a higher rate of pseudoarthrosis or failed fusion. Individuals that are advanced in age, older people obviously don't heal as well. Individuals with osteoporosis, and once again, the more levels included in a fusion, the more likely you are to obtain a pseudoarthrosis at one of those levels. And this is how we typically treated pseudoarthrosis. It's almost always, if it bothers the patient enough, it's almost always a surgical treatment. And what we did is we'd go in the back and we do this posterior fusion. So instead of this was the initial operation, and this was something that I did afterwards because the patient had a failed fusion. We used to go in the back and open the patient's neck up in the back, and then put all this hardware in, lock it down, and the patient would initially heal. But this is an operation that I hated doing, and the reason I hated doing this is because it's such a destructive operation. So here you see, this is an actual intraoperative image of us putting the hardware in there, but you can see how much atrophy these individuals have after surgery. The muscle mass just kind of completely goes away. And so you're taking away one problem by fixing the pseudoarthrosis, but in its place, you're giving these patients muscle atrophy, and you're giving them chronic pain because they're not using their muscles the way they should be. And so this to me was a very destructive operation. And from maybe the first time I started doing these operations frequently, I was always looking for a better way to do them. And this is that better way to do them. And I've been involved with this company on and off since its inception. This is truly a percutaneous way of obtaining a posterior spinal fusion. This can be done as an outpatient. Rather than using a fairly long extensile midline incision, It utilizes two small 1 to 2 centimeter incisions on either side of the patient's cervical spine. And because it's so minimally traumatic to the patient, I will oftentimes do this kind of an operation to supplement a standalone anterior cervical fusion at 3 or more levels, because it gives you a guarantee that the patient will ultimately fuse and you won't have to deal with this pseudoarthrosis down the line. And when you incorporate this minimally invasive posterior method, it increases the likelihood of obtaining a multi-level fusion, and obtaining a solid fusion after this kind of a procedure to near 100%. And this is how we do it. Through two small paramedian incisions, what we do is we insert this guidance device, and then we insert it in between the facet joints. We kind of rough up the facet joints, and then we insert a cage into the cavity created by the device, and we secure it to the spine. That cage is filled with bone, or it's filled with some type of bone graft substitute. And just by conferring additional stability to the spine as well as additional bone graft substrate, the rates of fusion approach 100%. So this is an individual, not the same individual as before, but we did a concomitant. He had the same problem. He was myelopathic. And so this is a 2 centimeter incision as opposed to a 1 centimeter incision because he had 4 levels improved. But nevertheless, this patient went home the first postoperative day feeling much better. And it's truly a very exceptional, in my mind, an exceptional technology for helping individuals get better without the trauma of this standard anterior and posterior open surgery. So I'm going to shift gears a little bit now that we're done talking about the cervical spine. If you'll remember, the two parts of the spine that wear out because they move are the cervical and the lumbar spine. The thoracic spine is stabilized by the rib cage. Rarely do we have problems in the thoracic spine. Very, very rarely do we operate on the thoracic spine. But as many of you are aware, we commonly operate on the lumbar spine and the cervical spine. So lumbar spondylosis, again, spondylosis just being a fancy medical term, which means degeneration or arthritis, is very similar to arthritis in other parts of the spine. Again, it begins with degeneration of the disc. As the disc degenerates, other structures become involved. You can have these bone spurs or osteophytes on the front or the back of the disc. The facet joints commonly in the lumbar spine become involved, and they can be a significant contributor to nerve compression. And oftentimes in the lumbar spine, as opposed to the cervical spine, it can be associated with some instability, like an L4-5 spondylolisthesis. And again, spondylolisthesis is a $10 word, which essentially means slipped vertebra, meaning one vertebra slips in relation to another vertebra, and that can significantly compromise the space for the spinal nerves. And we'll touch upon that in just a moment. So with lumbar spondylosis or with lumbar arthritis, there are typically 3 types of pain. You can have the axial back pain or the mechanical pain, which is from the disc being degenerative and the facet joints being degenerative, and that's pain usually localized in the low back and kind of a strap-like distribution at the base of the spine. Much like you do in the cervical spine, you can have radiculopathy, which is that toothache shooting kind of pain that goes down the leg in a very specific distribution. Or then much more commonly in the lumbar spine, you don't have any kind of spinal cord symptoms since you don't have a spinal cord in the lumbar spine, but you can have what we call neurogenic claudication. And that's these individuals who have a narrowed spinal canal will have discomfort in their buttocks. It's usually an achy kind of pain that extends down the back of the legs, oftentimes worse with standing and with walking, and reliably relieved by sitting down or resting. Okay. So lumbar stenosis is a process in which the spinal canal is encroached by arthritic structures. Stenosis is just a fancy word which means narrowing. Lumbar stenosis is narrowing of the lumbar spinal canal because of the surrounding arthritis, whether it's the disc and the bone spurs from the front of the spine, or it can be the facet joints in the back of the spine. And again, we talk about the neurogenic claudication, which is very common, usually in individuals, typically in their 50s to 70s. They'll have pain which starts in the buttocks, and as they stand up and walk, It gets progressively worse. It's a deep, achy kind of a pain. These individuals frequently will have decreased walking tolerance. It is reliably relieved by sitting down. And these individuals can have what we call a shopping cart sign, meaning that because they can have a significant amount of pain in their legs when they're standing upright, but if they're leaning forward a little bit and they're pushing something like a shopping cart or they're pushing a lawnmower, they actually relieve their symptoms because they actually expand the volume of their spinal canal. So this is a very common finding in individuals that have lumbar spinal stenosis. Usually the natural history is 30-30-30, about 30% improve with conservative care, whether it's physical therapy, injections, chiropractic management. About 30% stay the same but decide it's tolerable and they can live with it, and about 30% worsen and they eventually undergo surgical intervention. So I use this slide here to illustrate the different types of spinal stenosis, focal versus diffuse. You can see on the right slide how you've got multiple level disc degeneration. If you have multiple levels of disc protrusions and there is compromise from the facet joints in the back, if you look at how much space you have for the spinal canal up here and you come down to these 3 or 4 levels, you can see how this is very diffuse spinal stenosis. So it's compromise of the spinal nerves at multiple levels versus this right here. So this individual truly has what we call a spondylolisthesis or a slipped vertebra. And you can see how you've got plenty of space for the nerves up here, plenty of space for the nerves down here. But at this particular portion of the spine, you have severe spinal stenosis. And these individuals have very similar symptoms, whether it's diffuse or very focal. Conservative care is very similar between the two of them, but operative intervention can be very different. So obviously, as a conservative surgeon, we always try all the conservative stuff. We try the physical therapy, we try chiropractic interventions, we try different types of anti-inflammatories, we try gabapentin, we can try oral steroids and muscle relaxants. Lastly, there's epidural injections. And usually about 30% of the time, individuals will have substantial relief. If they don't and they're miserable, then we talk about surgical intervention. So degenerative spondylolisthesis, again, spondylolisthesis just being a fancy medical term, which means slippage of one vertebra. And the reason that's important is because that gives you very focal spinal stenosis. Okay, it's much like, so your spinal canal is, having a patent spinal canal is contingent upon having each of those rings perfectly stacked on top of each other. Okay, so each of these vertebrae has a ring attached to it in the back, which surrounds the nerves. And those nerves have to be perfectly stacked on top of each other, like a stack of wedding bands, perfectly stacked on top of each other, as we have in this left panel. In order to have a capacious spinal canal. But if you take one of those wedding bands and you move it out of alignment just a little bit, you can see how that significantly compromises the space for the nerves. And that's what's meant to be depicted by these two wedding bands that are kind of out of sync with each other. And you can see how the space in the middle is significantly compromised. Well, it's the same thing with the spine. So switching gears a little bit, this is one of my favorite operations, and it truly is. I mean, many of the things that we used to do open 15 years ago that would involve a 3 to 4 day hospital stay and 6 to 8 weeks of recuperation are no longer. We are so much better now at doing some of the same operations through minimally invasive techniques. And really what I mean by minimally invasive is smaller incisions, much more limited dissection, because you're working through much smaller incisions and you have much less dissection. It's much more X-ray dependent. We use these specialized fixation screws, which are coupled with these outriggers so that we can carefully manipulate these screws under X-ray within the wounds. And classically, again, because we're working through small incisions and limited muscle dissection, we're not able to directly visualize what we're doing some of the time. So there's classically extensive use of fluoroscopy or X-ray to ensure appropriate placement of instrumentation. And this is a classic study. Again, it's a little bit old now, but it's one of the best studies that we have. It's a prospective study between 50 patients treated with a minimally invasive technique. That's the 50 MIS TLIF patients and 50 open fusion patients with the same diagnosis. And that was a diagnosis of degenerative spondylolisthesis. And you can see back in the day, so back 12 years ago, the length of the hospital stay was halved. The time to return to work was halved, and there was significantly less narcotic usage in the minimally invasive group. And then they talk about some of the finances, which I'm not so interested in. But it's important to point out that now I just did a couple of these operations last week, and now these patients are going home the same day. So the length of the hospital stay is no longer 2 days. These patients are going home the same day with the appropriate blocks and the appropriate pain medications. And the time to return to work is frequently half of 6 weeks. It's now 3 weeks. So we've gotten better and better at utilizing these technologies. And I think we have more and more to offer patients at this point in time. So this stuff has clearly been borne out in the literature. The positive of minimally invasive lumbar surgery is that smaller incisions, less blood loss, less tissue trauma, muscle preservation, less postoperative pain, faster recovery, faster return to work, less complications, less cost. And as we get better at it, more and more procedures and patients are candidate for these minimally invasive techniques. The negatives being still not all procedures or not all patients are candidates. You have to have, there is a surgeon learning curve. You have to have a surgeon that's experienced in this kind of technique. There are patient limitations. Sometimes patients that have difficult anatomic anomalies, if they have osteoporotic bone or if they're significantly obese, they're not the best patients for this kind of technique, and depending upon the disorder that we're treating as well. Degenerative scoliosis is not something that is treated with a minimally invasive technique. So not everybody or not every disorder is a candidate for this technique. But again, as we're getting better, more and more patients and more disorders can be successfully treated using these techniques. So this is the standard setup. Usually there's two C-arms. A C-arm is a big X-ray device. One is over the top, one is lateral. It enables you to get an X-ray image simultaneously in the AP and the lateral plane. This is an individual that underwent a one-level minimally invasive fusion. She was out of the hospital the same day. This is her 4 weeks later. So you can see she's healed up her wounds. Her incisions are approximately 2 to 3 centimeters long. She's already doing bending exercises, and she's feeling much better than she did prior to surgery, with excellent relief of back pain and preoperative leg pain. So the last thing I want to talk a little bit about, and I'm almost done with this talk, is lumbar disc replacement surgery. And this is something that is truly excellent technology, but it's also something that is very limited. Not everybody is a candidate for this. I have probably 4 or 5 patients come into my clinic daily that ask about this technology, and there's probably only 1 or 2 weekly that are really good candidates for this kind of technology. And so this is used to treat lumbar degenerative disc disease at 1 or 2 levels in individuals that have chronic back pain and some degree of leg pain. So again, it's important to realize as a conservative surgeon, most patients are successfully managed non-operatively, and only a small subset of patients seek a surgical solution. Historically, what we used to do and we still do is fusions for a lot of these people. However, there has been a major multi-center study which has indicated that in the right patient, a lumbar disc replacement surgery can actually be a better option. And so here's an individual that has single level disease. You can see the remainder of that. This is his lumbar spine looking at it from the side. The square shaped things again are the vertebra, the discs in between. And I like to call this is my term for it, is a hamburger bun appearance. So these are all healthy discs. You have discs that have white on either side. Those are the buns. The dark line in the middle is the nucleus of the disc, and that's the patty. And you can see this individual has healthy discs all the way through until that very bottom one. And so this individual was likely a candidate for a lumbar disc replacement surgery because he has isolated disease at one level. He doesn't have excessive disc space collapse. He doesn't have excessive facet arthritis, and he's a younger individual. So this is my favorite total disc replacement. Again, much like the cervical disc replacement, it's a poly metal sandwich. The difference being the poly portion is much more constrained. The poly portion actually snaps into the metal portion of it, so it doesn't translate independently like the cervical one does. And the reason for that is because the loads in the lumbar spine are substantially more, as you can imagine, than they are in the cervical spine. The cervical spine simply has to support your head. The lumbar spine has to support your head and all of your torso. And so it's much more important to have a much more stable design. And this design is excellent. And so the goal of the surgery is to remove the disc and the pain generators, to restore disc height and mechanical stability, but still allow motion, maintain motion and spinal balance. And as it does in the cervical spine, you reduce, because you're preserving motion at the index level, you're reducing the potential for adjacent segment degeneration. So this is an individual that underwent a lumbar disc replacement. You can see these are X-rays, which indicate that this individual has preserved motion at the index level as well as preserved motion at the level above. This is an individual of mine, very similar to the one that we just saw, and you can see that he's got the hamburger bun appearance in all of the discs, except that very bottom disc, the L5S1 level, which is very collapsed, and you can see that the disc itself is very dark. This individual was a 31-year-old male who was very athletic. He was an avid basketball player, and he believes that basketball is what led to this injury. About 90% of his pain was back pain, and about 10% of his pain was right posterior thigh pain. He had exhausted conservative care in the form of chiropractic management, physical therapy, epidural injections, and a variety of medications, including gabapentin and multiple anti-inflammatory agents. And so this is this individual 4 weeks after surgery. So anterior approach, we went in, we took out the disc, and we put in the artificial disc. He had complete resolution of symptoms and was very happy 4 weeks after surgery. I was a little bit nervous letting him get back to getting back to activities like basketball 4 weeks after surgery, but I let him get back 8 weeks after surgery. He was back at it and then resumed all normal levels of activity, and was an extremely active individual the last time I saw him, which was approximately 2 years ago. So he's very happy. Excellent technology. Again, very limited indications. Not everybody's a candidate for it, but technology which is only going to grow, and more and more people are going to be candidates for this as we get better at it. And with that, I conclude my talk. I'll be happy to take any questions at this point. As Sarah indicated, I understand that there's a chat box that you can send your questions to, and I'll be happy to answer them at this point. And thank you for your attention.
Yes, amazing, amazing information. I learned so much, and I do actually have a few questions that maybe might help the audience as well that I came up with as I was listening. So learned so much. Thank you for that. So with regard to the anterior cervical fusion, I think it was what's that you named that your favorite surgery?
It's
Is
one of my
that
favorite surgeries.
one of your
Yeah,
favorites? Does that tend to be the most common, or what does tend to be the most common surgery that you do?
so the anterior cervical discectomy infusion still tends to be the most common surgery because, as I mentioned, more often than not, you have more than one level that needs to be addressed. Okay. However, I will make a great effort to identify candidates that are individuals that would benefit from the anterior cervical discectomy and disc replacement. And so, oftentimes I'll have a conversation with the patient, indicating that, listen, I think that the vast majority of your symptoms are coming from this level or these two levels. Now, there's another level that looks a little bit degenerative, but I think that we can get rid of your pain or get rid of most of your pain by doing an anterior cervical discectomy and disc replacement. And if that's the case, we'll do it. And so, while I still think that approximately 80% of cervical surgeries that I do involve some sort of anterior cervical discectomy infusion, a growing number of patients are now, and I would say about 20% of patients, or maybe 25% of patients, are now candidates for anterior cervical disc replacement surgery.
Yeah. Wow. Well, that's very helpful to know and understand as well. So I'm curious then, when you talk about all the, you've talked or touched on a few different causes and reasons that people might come in with back pain and whatnot, but I'm curious along those lines of causes, lifestyle prevention, anything that you would add to that?
So, I mean, the big issue, the three things that I harp on the first thing, a disclaimer, by the time individuals come to see me, I don't get a chance to really kind of preach to them because they've done a lot of conservative care and they've done a lot of, they've made the lifestyle adjustments to the extent that they can. I mean, a lot of patients have difficulty controlling their weight. So I usually see them at a stage further along when we're actually thinking about they've had different things, they've had physical therapy and injections, and we're actually at a point where we're considering surgical intervention. Having said that, probably the one thing that I would say is the is most closely correlated to individuals developing back pain, neck pain, arm pain is smoking history. Okay. Individuals that smoke, and it doesn't matter how much you smoke. You can be a 2 pack a day smoker, you can smoke 5 cigarettes a day, but individuals that smoke at all have 3 to 4 times the rate of problems that individuals that don't smoke. And we honestly don't know the reason for that. They also have difficulty with healing. They're more at risk for pseudoarthrosis and things like that. But I think I'm not going to stand on a soapbox here, but I think that if you've got a stack of reasons this high to stop smoking, that's one more to put on top of there. And it's something that I do mention to my patients, and I try to help them with throughout the course of their care. The other two, to a lesser extent, obesity. Certainly, individuals that are carrying more load tend to have a higher rate of back pain. And then conversely, individuals that are aerobically in shape, or there's been studies that have shown that individuals that exercise aerobically primarily, whether it's running or swimming, or have a lower likelihood of developing back and neck pain than those individuals that don't.
Very helpful. Thank you for addressing that. And then I'm curious too. Well, two things. First of all, it was really interesting also to hear about the same day surgery options. That
Mhm.
it seems like that might be something that has changed over the course of maybe the last decade, where you're not keeping people in the hospital overnight. Can you speak to that a little bit more?
Yeah, there's no doubt. I mean, part of it, not all of it is me. I mean, part of it is, I mean, some of these minimally invasive techniques just really lend themselves to outpatient surgery. And one of my other favorite surgeries is doing a minimally invasive fusion, which used to be a 3 or 4 hour operation, used to involve, a 3 or 4 day hospitalization, the patient's in a lot of pain, and seeing that patient go home the same day. And almost all the time, the only thing that keeps those individuals in the hospital is concomitant medical problems, like if there's a heart problem or if there's a lung problem or something like that. But that's one of the things that gives me greatest satisfaction, seeing a patient actually wake up and go home and feel better. And again, I can't take all the credit for that. A lot of that is different techniques with regards to anesthesia and giving the patient a preoperative block. And so a lot of it is anesthesia related, a lot of it is imaging related, but a lot of it is technique related as well. And so many operations. Obviously I still do the open stuff, and we still have to do that for people that have deformity or people that have a lot of multi-level problems. But this is the kind of stuff that is my bread and butter that I really enjoy doing, and I enjoy kind of pushing the envelope and trying different things in patients that are less invasive but still likely to give you the same outcomes as an open operation would.
Mhm. That's fantastic and truly speaks to the advancement of technology on multiple levels, but also, your expertise as well that goes alongside of that, which is great. So I think that lastly, the only thing I have left to really is just how people can get a hold of you. I have the phone number to reach you in October here, and I suppose people could probably call and make appointments now, but do they need a referral? Can you guide us through that a little bit?
Yeah, I think it depends upon your insurance plan. I mean, a lot of times, depending upon, what, I mean, I love to I'll see patients at any stage, and actually seeing patients earlier. In some ways, I can help them a little bit more by making It's not going to be an immediate fix. I mean, I can't. A lot of times, I'll see patients and they'll come in and say back pain. What can you do? What can and it's not something that's going to get better right away. But I will send, as a conservative doctor, I'll send them out for the physical therapy. I'll make the appropriate recommendations and things like that. I'm not all about surgery, although I love to help people that way. I love to help people surgically. That's not all of my practice. I do consider myself a conservative surgeon, also a minimally invasive specialist, but I do everything. So the office number here at Capitol in Des Moines is 515-440-2676. I'm going to be seeing patients on Fridays up in Boone at Boone Hospital, beginning at the very beginning of October. I don't have that number right now, but I think you do, Sarah.
I
And
do.
so I'm really excited for the opportunity and to come up to that part of the state and see patients that and bring something that hasn't been there or hasn't been there before. And I think it's going to be a good experience for everybody.
Yes, absolutely. I know we're very, very much looking forward to having your services here as well. And I do have that number, so I'll just read it off quick as well. So that is 515-433-8718. And it sounds like, I'm sorry, did you say people typically don't necessarily need a referral? They can work with you early on, or
Again, I'm not an expert in that. I think a lot of people probably would need a referral. I mean,
okay.
just because I am a specialist, I think they'd have to get it from their primary care doctor. But I see patients referred from chiropractors, and I see, but I think it's very insurance dependent.
Okay, got it. Got
Okay.
it. Okay. Well, thank you so much for your expertise, your information today. So much appreciate your time and energy and expertise as well. So, just for the audience to note that next month we'll be back in October with a women's health topic. So watch all of your normal news outlets to find out what that more information about that. And thanks again, Dr. Ibrahim. It is great to have you here today.
Thank you very much, sir. I'm really excited to be part of the community there, and I'm really excited to get started.
Thank you so much.
Thank you.
Right. We